This presentation is entitled Opioid Use Disorder: Science, History, and Clinical Implications. I will now turn it over to Dr. Soteri Polidorou to begin our presentation.
Good morning, and welcome to the Opioid Use Disorder session of our 2024 ASAM Addiction Medicine Board Review course. I'm Dr. Soteri Polidorou, and I'm the Medical Director of Addiction Services for Northwell Health. I have no financial disclosures. I'll be using a set of slides this morning, but I have hidden some slides just for the sake of time during the talk, but those hidden slides will still be available to you for reference. So during this talk, we will review current opioid use trends, identify important historical and regulatory factors that have impacted care, provide a neurobiological overview, review clinical assessment and management of opioid intoxication and acute withdrawal, and finally, provide an overview of medications for the treatment of opioid use disorder. The National Survey on Drug Use and Health is a survey of nearly 70,000 people aged 12 and older, conducted annually by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The survey provides critical insight on drug use throughout the US, and it's done each year. But there are potential gaps affecting SUD-related estimates. Specifically, the survey includes residents of households, but does exclude those without a fixed address, such as correctional facilities, homeless without shelter addresses, and mental health facilities. Even with those exclusions, they estimate nearly 3 million have a current opioid use disorder, which implies rates that are higher than HIV and type 1 diabetes. In addition, we tend to see about a 15-year reduction in life expectancy for those suffering from a severe opioid use disorder. On the right of the slide, you'll notice the leading causes of death in the US. Drug overdoses are incorporated into the third item on the list within unintentional injuries. If we look at drug overdoses as a separate component at over 100,000, it alone would still be a top 10 cause of death. If we break down the numbers further, since over 80% of all drug overdoses are secondary to opioids, lethal opioid overdoses alone would still be on this list. In addition, a high majority, over 90% of all opioid overdoses, are secondary to synthetic opioids, and that's largely fentanyl. So even that smaller component of total lethal overdoses, specifically those related to synthetic opioids, which again are predominantly fentanyl, would also be a top 10 cause of death in the US. Over approximately the past decade, opioids, which is the black line on top, and specifically synthetic opioids, again, predominantly fentanyl, and that's the brown line just below the black line over the past couple of years, has been the leading factor resulting in the rise of overdose deaths in the US. If we take a somewhat longer-term perspective over the past 25 years, we appreciate three distinct factors leading to rising opioid overdoses. These three waves, starting in the very early 2000s, predominantly driven by prescription opioids, followed in early 2010 by escalating heroin overdoses, and more recently, beginning around 2013 and continuing to this day, the rapid rise from fentanyl overdoses. It's important to note, though, that prior to 2013 to about 2015, fentanyl overdoses were comparatively so uncommon that it was not routinely tested for by many medical examiners, and that includes even in New York City. From a national perspective, drug overdoses have thankfully begun to decrease. There's been a 3% reduction from December of 2022 to December of 2023. Yet we continue to see areas with both large percentage increases, such as those in Washington State, Oregon, Nevada, and Alaska of over 20%, as well as in some urban areas, such as Washington, D.C., of nearly a 10% increase. And as we look to understand the overdose risk from illicit opioid use, here's data primarily from non-treatment seeking heroin users, indicating the high personal risk of experiencing and witnessing an overdose at roughly 50% and 70% respectively. In addition, there's about a 5% one-year mortality for those presenting to EDs or get admitted for non-fatal overdose. Now let's move from opioid trends and use trends to history. So when did this all start? We know it was before the 90s, and it was before the 70s, and even before the 1900s and before the 1800s. We have evidence from over 5,000 years ago of the purposeful cultivation of the opium poppy, Papaver somniferum, which contains multiple naturally occurring alkaloids, and that includes morphine and codeine. The opium trade began in the Middle East and rapidly spread throughout the world. It became very lucrative, and as opium grew in commercial importance, including for the British East India Company, which some may remember from old social studies classes, it eventually led to conflict. By the late 1700s, the opium trade was an established business, continuously in search of new markets. China was a very large market, and the importation of opium dramatically increased, leading to escalating addiction and resulted in the Chinese emperor ordering an embargo of all opium imports. Ultimately, the emperor ordered the confiscation of all opium and destroyed all found supplies. The British charged the destruction of their commercial property, leading to the First Opium War. It concluded in 1841, with China paying a large indemnity and ceding Hong Kong at that time to the British for over 150 years. Interestingly, diacetyl morphine is developed in the late 1800s and soon becomes commercially available and sold by the Bayer Company. Diacetyl morphine was quickly identified to have more potent analgesic effects than morphine and codeine, and quickly was marketed as an aid for a whole host of ailments, things from insomnia to pain to cough and fever. Also, interestingly, early study participants testing diacetyl morphine reportedly described the drug as making them feel heroic, and that stuck, and heroin was introduced. In the early 1900s, public health hospitals are established in Fort Worth, Texas, and Lexington, Kentucky. And they explored both the clinical effects of various addictive substances, including opioids, and early treatment models. In reaction to the US's own domestic rise in opium addiction in the 1800s and early 1900s, the government does respond here as well. A number of laws and regulations are introduced, opium's banned in 1905, and soon thereafter, labeling of all medications by pharmaceutical companies is required. In 1914, the Harrison Narcotics Act regulates and oversees all manufacturing and distribution of opioids and coca products, and that strictly limits their use to treatment by physicians with a very specific language in the regulation, which described it as physicians in the course of their professional practice only. So physicians can only use opioids or coca products in the course of their professional practice only. And the reason why this stipulation was important is because that's how opioids continue to be used in medicine as an analgesic. However, the treatment of addiction was also commonly being addressed at that time by physicians as part of their routine practice of medicine. After the Harrison Narcotics Act, that all changes. Physicians soon discover that using opioids in an attempt to treat addicted patients could not continue. Physicians began to be arrested because addiction at the time was not considered a disease. Therefore, physicians could not justify using opioids in the treatment of opioid-addicted patients. Between 1919 and 1935, 25,000 physicians are indicted. And I'll repeat that again. 25,000 physicians were indicted, and 10% were imprisoned. The US Supreme Court eventually strikes down arresting physicians for treating addicted patients, stating that the federal government had overstepped its authority to regulate the practice of medicine. But the damage at that point was largely done. Ultimately, we are still working to remedy the effects of that early and very sudden separation of addiction treatment from the general healthcare system. It takes from that point nearly another 50 years before a long-term medication-based treatment for opioid use disorder becomes available for patients. Starting with methadone, studied early on by Dole and Neiswander in the 1960s and authorized in the 70s to be dispensed only by specifically licensed clinics. Those were originally referred to as methadone treatment programs and now known as opioid treatment programs. Continuing with the introduction of buprenorphine in 2000, partly in an effort to expand treatment beyond those able to receive care at OTPs or opioid treatment programs, buprenorphine afforded a broader group of healthcare providers to begin offering opioid use disorder treatment. But prescribing buprenorphine early on also came with restrictions. Initially, only 30 patients per physician. Each physician had to complete an 8-hour course, and there were other criteria before a provider could receive their waiver. And that waiver is referred to sometimes as a BUP waiver or a data waiver or an X waiver. Those are all the same thing. And the following 20 years after the Data Act of 2000, those that are able to prescribe buprenorphine is expanded. So from physicians to other advanced care providers, and the number of patients that each prescriber can provide buprenorphine to rises over time from 30 to 100 to 275. But what we also learn is that while the total number of providers able to prescribe buprenorphine grows, there remains only a small group of providers that are prescribing buprenorphine to the majority of patients. So again, even though the absolute numbers of waived providers of buprenorphine grows, still we tended to see a very small percentage of that overall number providing and prescribing buprenorphine on a regular basis to patients. And then just last year in 2023, the Mainstreaming Addiction Treatment Act, or the MAT Act, is passed as part of the 2023 Consolidated Appropriations Act. This eliminates the previously required buprenorphine waiver. Buprenorphine prescribing now only requires a standard DEA license. There are no longer caps on the number of patients a prescriber may treat for opioid use disorder. However, the MAT Act is federal, so it does not impact existing state laws or regulations. So it's important to know, depending on the state that you practice in and the local regulations, if there's anything else that may apply in addition to the MAT Act. And just earlier this year, in 2024, federal regulations which impact opioid treatment programs and their accreditation agencies, such as the Joint Commission, were updated. And that regulation is called 42 CFR Part 8. The updates here supported the increased access to OTPs by replacing previous admission criteria with the current diagnostic criteria of moderate or severe opioid use disorder that could be current or in remission, as well as those patients who are at high risk for recurrence of opiate use or are at high risk of an overdose. So that broader group of patients would meet admission criteria to an opioid treatment program now. It also facilitates a treatment initiation by expanding use of telehealth and the use of non-opioid treatment program providers to perform admission evaluations. Now, again, 42 CFR Part 8 only applies to opioid treatment programs. There are a number of additional changes that are authorized. Some are highlighted here, which includes patients at OTPs being able to receive methadone even if they refuse counseling. Other important rule change impacted the frequency patients present to the OTP to pick up medication. As an example, prior to this rule change and the temporary changes from the 2020 public health emergency, patients who were starting on methadone and new to an OTP were required to present to the clinic daily. And no clinic could be closed more than one day a week So what that implied is that patients either were coming to the clinic 7 days a week if the clinic was open, or 6 days a week if the clinic was closed 1 day a week, for a daily methadone dose at the start of treatment. Only a patient-specific waiver requested by the OTP and approved by federal and state agencies would allow any flexibility to that daily attendance requirement. That federal attendance requirement has now changed. So patients clinically determined to be able to attend the clinic less frequently could receive take-home methadone doses for up to 1 week, even from the start of treatment at the OTP, and quickly increase to once every 2 weeks, and then once per month. This is a very significant change in the flexibility that was afforded to both opioid treatment programs in aligning their clinical decision-making and their determination of the appropriate attendance schedule for patients with the changes in the federal regulations. The regulation also supports providers by including 6 criteria the OTP medical director or other OTP provider should consider when determining a patient's attendance frequency, and they're listed here on the slide. Now, let's proceed from opioid regulations to starting to discuss neurobiology. And as in the neurobiology of addiction session, various addictive substances enhance extracellular dopamine levels, which is also the case in exogenous opioid receptor binding. So in terms of terminology, let's just remind ourselves. So endorphins is the endogenous class of opioid ligands. So some examples here are beta endorphin and enkephalin dynorphin. Opioid is a much broader description of both exogenous or non-endogenous, natural or synthetic opiates, and endogenous compounds that bind to one or more types of opioid receptors. And then finally, opiate refers and describes compounds that are naturally derived from the poppy plant. So examples here would be morphine and codeine. The opium poppy, Papaver somniferum. It's important to note that the alkaloid content of opium includes substances other than morphine and codeine, and some of which do not have morphine-like effects, such as noscapine. So there are 5 alkaloids that are part of the opium poppy. Morphine is isolated in 1806 from opium, and its chemical formula is identified about 40 years later. Thebaine is an intermediate for semi-synthetic opioids. And so it's also important in the development of oxycodone and buprenorphine. So again, important to keep in mind morphine type effects from obviously morphine and somewhat similarly codeine, noscapine not having morphine-like effects, and thebaine being an important intermediary for the development of other semi-synthetic opioids. In terms of binding, endogenous opioids and opioid receptors, let's review for a second. So beta endorphin and endomorphin bind to mu opioid receptors. Dynorphin binds to the kappa opioid receptor, and enkephalin binds to the delta opiate receptor, and orphanin or nociceptin binds to the ORL or opioid receptor like 1 receptor. And then more broadly for opioid receptors, there are some common elements to all. They are all opioid receptors, irrespective if it's mu or kappa or others, all have 7 transmembrane domains. All are G protein coupled, and they are primarily inhibitory pathways. So the mu opioid receptor again, activated predominantly by beta endorphin. It reduces cyclic AMP, and the physiologic effects are related to intoxication and withdrawal. The kappa opioid receptor, again, activated predominantly by dynorphin A, and that mediates dysphoric activities, both interestingly from opioids, but also cannabinoids. It also opposes mu receptors in regulating hedonic tone and modulates stress-induced relapse. Delta opioid receptors, predominantly again activated by enkephalin, and these receptors are pretty distinct from mu and kappa receptors. Delta receptors play predominantly a role in emotional responses, and some studies have showed anxiolytic activity as well. In addition, there has been some identification of some benefits in analgesia, particularly related to inflammatory causes of pain. The endorphin system has a role in many normal physiologic functions. Some systems are noted here. The effects of exogenous opioids include sedation, analgesia, euphoria, constipation, nausea, urinary retention, vasodilation, reduction in testosterone and FSH-LH, and increases in prolactin. In addition, some opioids, particularly methadone, can prolong the QT interval, raising concern for the risk of VT. The potency of different opioids also varies. Diacetylmorphine is twice as potent as morphine. Fentanyl is 100 times more potent than morphine. And other synthetic opioids, such as carfentanil, are even more potent. We now move from neurobiology to intoxication and withdrawal. To begin, I suggest we think about medications in the context of addressing an overdose, or treating acute withdrawal symptoms, or long-term treatment with relapse prevention. As an example, our treatment goals differ when intervening during an acute overdose as compared to providing withdrawal symptom stabilization, or when we provide long-term maintenance treatment. The classic triad in overdose is meiosis, decreased level of consciousness, and respiratory depression. Also important to note that at times we do see pulmonary edema, and some opioids increase the risk of seizures. So meperidine and tramadol also increase risk of seizures. So considering not only the classic triad, but also pulmonary edema and seizures again specifically dependent on specific opioids. So what about the management of an overdose? So ventilatory support if needed, supportive interventions, and primarily naloxone intervention, parenteral naloxone, IV is available, sub-Q or IM, and from a public health perspective, certainly with the expansion and important role of overdose prevention and naloxone kits, intranasal administration of 2 doses of naloxone, and each dose generally now in overdose prevention kits are routinely 4 milligrams. From overdose interventions, let's proceed to withdrawal symptoms. Here's a diagram from the New England Journal of Medicine describing the acute withdrawal symptom severity and duration associated with heroin, methadone, and buprenorphine. And as you can see from this diagram, it is generally thought that heroin having a shorter duration but higher intensity of opiate withdrawal symptoms, methadone, abrupt discontinuation is a less intense but longer duration of withdrawal symptoms, and buprenorphine, again, less intense compared to diacetylmorphine and shorter than methadone. There are a number of scales to help quantify opiate withdrawal symptoms and can be helpful, particularly to assess these symptoms over time. This is the COWS scale, the clinical opiate withdrawal scale, and that includes 11 areas of assessment and quantifies withdrawal symptoms ranging from mild to moderate to severe. Acute withdrawal treatment is primarily managed utilizing buprenorphine or methadone, with the addition of non-opioid symptom-focused medications. We'll discuss dosing and titration of buprenorphine and methadone in detail later in the talk, but important, though, to note that buprenorphine is available in a variety of clinical environments, while methadone availability is significantly more limited. In terms of specific opioids and complications to be mindful of, we mentioned meperidine is increasing risk of seizures. Some opioids also increase the risk of serotonin syndrome. So again, meperidine, tramadol, and tapentadol. Kratom, interestingly, at low doses has more of a stimulant effect, but at higher doses has an increasing opiate-like effect. That analgesia of high-dose kratom can be, and the sedation associated with it can be reversed by naloxone. And there is a thought that there's some potential association with hepatic cholestasis, which may be dose-dependent when using kratom. Tianeptine is an antidepressant that is widely available in Europe. It's similar in many ways to TCAs. There is some U and delta agonism that's there, and there are anticholinergic symptoms that can also be present with high-dose tianeptine use. Some other items that are important to keep in mind, particularly test-related type questions. So do be mindful that naloxone intervention for overdose may need to be repeated, particularly for long-acting opioids such as methadone or highly potent opioids like fentanyl and carfentanil. The fentanyl chest wall rigidity or skeletal muscle rigidity, that results in very rapid respiratory arrest. It's most common with rapid IV administration of fentanyl, but it does not seem to be dose-related. This is a medical emergency. Urgent ventilation is needed. Naloxone urgently is needed, and a neuromuscular blocking agent urgently is needed. Xylazine and more recently, metitopidine. These are not opioid sedatives. These are alpha-2 adrenergic agonists, but they are more and more commonly identified with illicit fentanyl. These substances are sedating. Naltrexone is not effective, again, because they are not opioids. Also, because they are not opioids, withdrawal is not addressed by methadone or buprenorphine treatment. But these substances can be associated and are associated with complex and progressively severe wounds. So important clinically to keep them in mind. And then, as always, important to be mindful of, polysubstance exposure, be it acetaminophen or others related to overdoses. In terms of clinical areas to focus on, let's start by noting that pharmacotherapy for opioid use disorder treatment compares favorably to other medications we commonly use. They share an extensive evidence base of improved outcomes, and over 1 million people are currently benefiting. Some of the examples of the improved outcomes are reduced use of illicit opioids, longer period of abstinence, retention in treatment, decreased medical and psychiatric symptoms, improved health, reduced risk of HIV and hepatitis C infection, along with a number of social improvements, such as maintaining or obtaining employment, improving family relations, and decreasing criminal justice involvement. But there's really one more very, very important benefit to highlight, and that's methadone and buprenorphine treatment reduces overdose risk. The evidence is incredibly clear on this, that methadone and buprenorphine treatment reduce overdose risk. And we'll discuss just a couple of studies to kind of highlight some of this. This study from the University of Maryland looked at the association between the expansion of methadone and initial buprenorphine treatment expansion. So the green dashed line, which is kind of at the bottom in 1995, is buprenorphine, and then you see soon after 2000 the number of patients on the right side being treated with buprenorphine increases. The kind of alternating dashed blue line is patients who are receiving treatment on methadone, and then the red line is the number of overdose deaths. And this was all done in Baltimore from 1995 to 2009. And so even though during this period the heroin purity increased, expansion of access to buprenorphine treatment was associated with almost a 40% annual decline in heroin overdose deaths. So let me just repeat that, because commonly in medicine, we don't see reductions this high with such an important outcome measure, such as an overdose death. So expansion to buprenorphine treatment was associated with a 37% annual decline in heroin overdose deaths. Another study, this is a retrospective comparative effectiveness study, which included over 40,000 adults with opioid use disorder, and it compared 6 different treatment pathways. In this study, only treatment with buprenorphine or methadone was associated with a reduced risk of overdose and serious opioid-related acute care use at 3 months and 12 months of follow-up. This retrospective cohort study of 17,000 opioid overdose survivors, which we know remain at a very high risk for death, looked at whether the use of medications for opioid use disorder after an overdose would be associated with reduced mortality. In the 12 months after a non-fatal overdose, compared with no medications for opioid use disorder, both methadone and buprenorphine were associated with decreased all-cause mortality and opioid-related mortality. A point of concern, though, only about a third of opioid overdose survivors in the study received any methadone, buprenorphine, or naltrexone. So buprenorphine. Buprenorphine onset of action is roughly 30 minutes to 60 minutes. Its peak effect is about an hour and a half. It's metabolized through CYP3A4. It can alter liver enzymes, so it is important to periodically monitor liver function for patients on buprenorphine maintenance. Very safe in pregnancy. There are a number of studies that have looked at this. Initially, the mother study, I believe originally published in JAMA, which showed for babies born to mothers on buprenorphine, reduced morphine use, lower neonatal abstinence syndrome symptoms, and reduced hospitalization days. There are multiple FDA-approved formulations of buprenorphine available. There's daily sublingual films, there's tablets, there's monthly and weekly sub-Q injections. Buprenorphine is a partial mu-opioid receptor agonist and kappa, receptor antagonist with high affinity and slow dissociation from the mu-opioid receptor. So therefore, clinically, at low doses, it acts as an opioid agonist. But for those with physical dependence and recent opioid use without withdrawal symptoms, sudden initiation at too high of a dose will result in a clinical antagonistic effect or acute iatrogenic opioid withdrawal. And that's what this graph here on the bottom looks to represent, which is the high affinity but partial mu agonist effect of buprenorphine. When introduced at too high of a dose, and somebody is physiologically dependent and recently using full agonist drugs such as heroin, if they take too high of a dose of buprenorphine before experiencing withdrawal symptoms, the buprenorphine will precipitate or initiate withdrawal. There are a number of strategies when inducting patients onto buprenorphine. This slide includes a well-established process. There are, however, a number of other protocols, some that use more rapid dose increases with some up to 24 milligrams on day 1, and others using much lower initial doses or microdosing, commonly a 0.5 milligram sublingual and titrated up over a few days to a therapeutic dose. The benefit of low dose or microdose protocols is that a patient does not need to experience opiate withdrawal symptoms prior to initiating buprenorphine and can potentially continue to use other opioids for a period of time during the early parts of the titration process, again, to avoid that experience of needing to experience mild to moderate withdrawal symptoms before initiating buprenorphine treatment, which can in itself be a significant barrier for many patients who would otherwise be interested in starting buprenorphine. Here's a resource with information on FDA-approved formulations for opioid use disorder. So these include, essentially all of the FDA-approved formulations of buprenorphine to treat opioid use disorder with the various doses available as well. Naltrexone. Naltrexone is a long-acting, competitive, non-selective opioid antagonist that has a very high affinity to the mu-opioid receptor. It's metabolized by CYP450. Its active metabolite, which can be found in the serum, is 6-beta naltrexone. And at high doses, important to note that naltrexone has been identified and associated with hepatic toxicity. It is contraindicated if there are significantly elevated transaminases. And again, monitoring a patient while they're on naltrexone is warranted periodically. Because naltrexone is a mu-opioid antagonist, those with current physiologic dependence who are on opioids need to first receive withdrawal treatment. In general, that really more commonly takes about 1 to 2 weeks for someone to go through withdrawal treatment before starting naltrexone. Low adherence rates with the oral formulation from a number of studies frequently limits use to highly motivated populations with some support for adherence. The long-acting IM formulation is therefore preferred. The medication is administered monthly in office. A number of studies have supported its use for opioid use disorder. One additional item, though, I want to comment on is that it's still important to be mindful of the overdose risks from interrupted antagonist treatment. In the studies that looked at extended release naltrexone, the reported overdoses were very low. However, clinically, it's still important to be aware of that because those patients that are suddenly interrupted on their antagonist treatment, at that time, they would have no physical tolerance to opioids. And so relapse could potentially increase the risk of overdose. Methadone. Methadone is approved by the FDA for opioid use disorder in 1972. It is a mu-opioid receptor agonist and an NMDA antagonist. There are 2 equal enantiomers that are usually in equal amounts. There's the R, which is active, and the S, which is inactive. It is metabolized by CYP450. And although the metabolism is rather complex for methadone, it's excreted actually both in urine and feces. And so that Clinically, it is important to recognize because it avoids accumulation and reduces the risk of toxicity for patients with renal failure or liver failure. Half-life has a wide range. Generally is about 24 to 36 hours, but can be as short as 4 hours, can be as long as 91 hours. Because of this highly variable half-life, it is really important to avoid rapid titration of methadone. In 2006, there was a black box warning noting the risk of QTc prolongation. Common side effects for methadone include constipation, sweating, and to a lesser extent, sexual dysfunction. Do be mindful also of opioid conversion tables. Methadone is different than most other opioids, where traditionally you will see in conversion tables a static ratio of 1 opioid to morphine equivalents. For methadone, that ratio changes based on the total number of morphine equivalents. So be cautious about the use of opioid conversions when utilizing methadone and starting methadone. It is important to just be mindful of starting methadone at lower doses and titrating methadone slowly over time. Again, considering its long half-life. In terms of initiation doses, 10 to 20 milligrams orally or half that dose as IM. 20 milligrams eliminates severe withdrawal. First 24-hour doses generally are between 20 milligrams and 30 milligrams total. It is generally not routinely recommended to exceed 40 milligrams in the first 24 hours. However, the recent 42 CFR Part 8 update did note the potential to increase up to 50 milligrams. But again, here I would encourage caution. Cravings tend to be addressed at higher doses of methadone, and so continuing titration of methadone from a low initial dose and increase by 5 to 10 milligrams every 3 to 7 days. Generally, cravings and the blocking effects of methadone tend to have more of an impact at doses of 80 milligrams of methadone and up. In just being aware of the basics of all opioid treatment programs, and again, important to note because methadone is available in licensed opioid treatment programs in the ambulatory environment for opioid use disorder. OTPs have comprehensive assessments. They have well-established multidisciplinary treatment planning, toxicology testing, diversion control. And so there is a structure and a process around OTPs that that impacts care, in addition to the availability of medications and beyond even the availability of solely methadone. OTPs routinely provide not only methadone, but buprenorphine and naltrexone. So as a comprehensive treatment for opioid use disorder. When treating patients with fentanyl, for a fentanyl opioid use disorder, it's helpful to consider just a few additional items. So fentanyl, as we mentioned earlier, has a greater potency than morphine, and it also preferentially affects respiration over analgesia. And there we really run the risk of a very rapid, prolonged respiratory depression. Pronounced noradrenergic toxicity that can result in laryngospasm and, as mentioned earlier, chest wall rigidity. Fentanyl results in tolerance and physical dependence, and that could potentially be greater than what is typical for someone using large amounts of heroin daily. So in addition, the withdrawal that we tend to see with fentanyl tends to have a later onset. Instead of 12 to 24 hours, or sometimes a little shorter, for fentanyl, we tend to see 2 to 4 days after cessation. So just taking all that together, some of the previously established clinical recommendations when using and initiating methadone, buprenorphine, or naltrexone, they continue to be revised in recognizing some of these changes and clinical impact of fentanyl. Whenever deciding on a medication and a treatment environment, important to consider the different the assessment of the patient. Is the patient focused more on abstinence, or is the goal of treatment harm reduction? Is chronic pain, or is there a foreseeable need for opioid use for the patient? Is the patient pregnant or planning pregnancy? Here's a list of items to consider clinically as you think about which medication may be a preferred option for your patient. Now, if we go into some questions, and please, I'll read through the question. I'll go through all the different options. And if you can put your answer and indicate your answer on the side. In addition, if you have any questions at any point, please also put them in the chat so that they can be addressed as well. Which endogenous opioid receptor type predominantly influences the development of acute opiate withdrawal symptoms? Option A is GABA B. Option B is the kappa opiate receptor. C is the mu opiate receptor. D is the serotonin 5-HT2A receptor. Again, let me read the question. And when you're ready, if you can indicate your answer. Which endogenous opiate receptor type predominantly influences the development of acute opiate withdrawal symptoms? A, GABA B. B, kappa opiate receptor. C, mu opiate receptor. Or D, serotonin 5-HT2A receptor. The correct answer is C. We discussed this as we reviewed the neurobiology review, and you can find more detailed information in the most recent ASAM Principles of Addiction Medicine textbook as well. Next question. Which of the following is the correct order from most to least relative opioid potency? Option A, carfentanil, fentanyl, diacetyl morphine, morphine. B, fentanyl, carfentanil, diacetyl morphine, morphine. C, diacetyl morphine, carfentanil, fentanyl, morphine. D, morphine, diacetyl morphine, carfentanil, fentanyl. Again, I'll repeat. Which of the following is the correct order from most to least relative opioid potency? A, carfentanil, fentanyl, diacetyl morphine, morphine. B, fentanyl, carfentanil, diacetyl morphine, morphine. C, diacetyl morphine, carfentanil, fentanyl, morphine. D, morphine, diacetyl morphine, carfentanil, fentanyl. The correct answer is A. Carfentanil is the most potent at over 10,000 times the potency of morphine. Fentanyl is next at 100 times the potency of morphine. Diacetyl morphine is then twice the potency of morphine, and then finally morphine. And the final question. The federal 2024 HHS update to 42 CFR Part 8 authorizes the following at accredited opioid treatment programs except, so option A, up to 7 unsupervised take-home doses of methadone for patients recently admitted. B, medical directors may delegate some responsibilities to other practitioners. C, medical exam requirement modified to facilitate treatment initiation. Or D, counseling is required for patients obtaining care at OTPs. Let me repeat this again. The federal 2024 HHS update to 42 CFR Part 8 authorizes the following at accredited opioid treatment programs except A, up to 7 unsupervised take-home doses of methadone for patients recently admitted. B, medical directors may delegate some responsibilities to other practitioners. C, medical exam requirement modified to facilitate treatment initiation. Or D, counseling is required for patients obtaining care at OTPs. Please indicate your answer. And the correct answer is D. Counseling is required for patients obtaining care at OTP. So that's not accurate. In the most recent regulations, counseling is specifically not required for patients to receive care with methadone and opioid treatment programs. The link is available directly to the federal regulations on some of the slides that we reviewed. The formal regulations are in total 38 pages, but the section on clinical applicability and guidance is much shorter than that 38 pages. It's really only about less than 10 pages. And so I would encourage anyone who is interested in learning more about the federal regulations on opioid treatment programs. I would strongly recommend taking a moment, reviewing that information. And again, it's only a few pages and can be really insightful in understanding the regulatory framework around opioid treatment programs. And again, the slides we used during this talk will all be available, as well as some additional slides with some more details on the topics we discussed. Just want to thank you for joining the session and good luck on the exam. Thank you.